Thank you. I'm excited to talk to you about LAMS. These are my disclosures. So one thing that is important to say is that this is a game-changing technology, and there has been now recognition by our societies as well as strong support. And you can find excellent reviews of this technology available with all of our societies, including ESGE and the ASGE, which really describe the various different LAMS. We know the Axios most commonly, but it really goes into quite a bit of detail, what's available via hot, or using cautery, non-cautery, the sizes, the dimensions overall, as well as the delivery systems. So I would advise you to review these if you're further interested in information. Just a little history and description of why LAMS really even developed. If we think about EUS-guided procedures, traditionally had been reserved for pancreas fluid collections and walled-off necrosis, and we used the Seldinger technique, where we placed the EUS needle. Actually, it originally started with blind access using a needle knife, and then placing a wire. We then recognized the need to be able to see what's on the other side, so we started using EUS FNA needles, placing wires through that needle, and then everything was done over the wire. And our stents were pretty rudimentary. They were relying on things we used for biliary access, such as double pigtail stents or even biliary covered metal stents. But what the problems here were that there were multiple exchanges needed when you do anything over the wire. There could often be loss of access, separation of the lumen walls during deployment, which results in leakage and perforation. These were small diameter stents, oftentimes resulting in stent occlusion, needing to dilate, and further complications based on that. The stents would migrate or they would be too long, and this definitely required fluoroscopy in order to be performed. So the solution was to develop two things. One is EUS-guided cautery direct access, where we didn't have to do these exchanges, and the second was a deployment system that allowed for everything to happen at one time, and a stent that could really hold the walls together. And so now we have what you know as the LAMS. It's a fully covered lumen-opposing metal stent. They come in two forms, cautery-enhanced and non-enhanced, multiple sizes, anywhere from 6 millimeters to 20 millimeters in diameter, and 10 and 15 millimeters in length. These techniques can be performed either wire-guided if you choose to, or freehand, which has changed the game for quite a number of procedures. And again, using only EUS as well as using fluoroscopy. So that also changes the settings in which we can perform these procedures. And originally, it is important to note that this was only indicated for drainage of pancreatic fluid collections and walled-off necrosis, but what we've seen is that by applying techniques in principle, we have really expanded these indications to things like EUS-guided gallbladder drainage, choledochoduodenostomy, enteral access, and even other one-time access or anastomosis creation. It really does allow us to push the edge of innovation and is a game changer. So starting off with fluid collection drainage, this again was the original indication and purpose of developing the lumen-opposing stent. In principle, EUS-guided drainage has been well established as first-line therapy for these fluid collections, particularly if they're infected, you're having failure to thrive, or they're causing symptoms of obstruction. Early drainage is now available due to use of LAMS, and there are different techniques that we can do, such as multi-gate drainage if you have a large collection, as well as the same-day necrosectomy using the larger LAMS. We have developed now protocols for how to use, how to consider different types of collections and the role of LAMS versus plastic stents. This was the Orlando protocol that was developed and really goes into whether or not collections are pseudocysts or necrotic collections, how big they are, and whether or not a single LAM should be placed versus multiple access points, as well as things like double disconnected duct syndrome. And also things like paracolic fluid collections that can also now be dealt with once we establish a point of access using LAMS. This is supported by the most recent Destin trial that showed that fewer interventions required with upfront, meaning same-day procedures done when you placed a larger lumen-opposing metal stent and then followed it with necrosectomy versus a step-up procedure with no differences in mortality, procedural, or disease adverse events. So this is the procedure itself. This is a walled-off necrosis. You see the cautery catheter entered. Now we deploy the first flange or the distal flange, oppose the two walls, so pull it up, and then the second flange is being deployed inside the channel of the scope. You don't see anything happening, and that is followed by pushing a deployed stent, a deployed flange out of the channel. This can be dilated, again, depending on whether you're going to follow it with same-day necrosis. Technical success rates are very high with this procedure, clinical success rates as well, and original adverse event rates were quite high, but this has changed quite a bit with increased knowledge of how to manage these stents. Of course, it does remain a question, should we be using these stents all the time, or is there a role for plastic stents? There are a couple studies, including this non-inferiority study, that showed no difference in the number of procedures performed, the success rates, but a shorter duration of procedure. Initially, there was an increased rate of adverse events with these, but again, once we learned about when these should be removed, and that helped decrease the bleeding rate, which has now normalized adverse events. But it is associated with an increased cost, and this will remain an issue. Another study showed that there were significantly higher success rates, similar success rates, but shorter time to resolution, decreased episodes of recurrence, and decreased number of requirements for surgical necrosectomy using the LAMS. In this case, the adverse event rate was higher with LAMS, however, it was mostly due to stent misdeployment, which again speaks to the necessary training prior to starting to use these procedures. We have multiple sizes, as I mentioned, so what size should we be using? Really, there's no difference in the technical or clinical success rate between the two. However, using the larger LAMS, the 20 millimeter, does allow for same-day necrosectomy and use of devices such as the powered debridement catheter called endorotor that can either be placed through a 6 millimeter channel scope, which is a very large diameter scope, or placed over on a guide sitting on the outside of a scope, but the large diameter of the LAMS does allow for us to go in immediately, if necessary, and treat these patients and potentially decrease the number of procedures required. Of course, we always have to consider complications of these procedures. Bleeding, pneumoperitoneum, pseudoaneurysms, tract occlusion, and infection have all been described, as well as stent migration. In this study, looking specifically at adverse events, they found that the overall adverse event rate was about just less than 25%, but most of these were moderate in severity and could be managed endoscopically. And if you broke that down a little bit, early complications were associated with bleeding and infection versus late complications associated with the stent migration or occlusion. Again, this has kind of guided us towards stent management, when to remove them, and when to go in and do further therapy. One of the most important things to note is that when we realized the bleeding could be associated with the stent itself, it became sort of protocol to really repeat imaging after 3 weeks, and if a collection was resolved, to make sure that the stent was removed. And now that we know that we can use it for pancreatic fluid collections, we can really use it for any collection, such as liver abscesses, gallbladder abscesses, and pelvic abscesses. There's no real good data on this, but essentially the techniques are the same and the concept is the same once you have a walled-off collection. So the second most common indication now is EUS-guided gallbladder drainage. Here you can see it is very much like a pseudocyst, but it's important to remember that the gallbladder is not fixed. So it is a mobile organ and does therefore require a little mindfulness about the procedure and the techniques that we use. But this is a very effective technique. It has very good success rates in both technical and clinical. Its adverse event rate, again, is about 20%, usually related to stent misdeployment, but sometimes also food impaction. And this may guide us in the size of the stents that we're using, like the 8 and the 10, as opposed to a 15 or a 20. It's contraindicated if there is a perforated gallbladder, there's presence of ascites, or a large distance between the gallbladder wall and the luminal wall, and or if the gallbladder is contracted. It has been described that this is most safely done using electrocautery-enhanced LAMS, as well as using the freehand technique as opposed to advancing a wire and performing it over a wire. And it does allow for further therapy, for example, removing stones, performing EHL or laser lithotripsy, and even converting percutaneous drains into internal drainage for those patients who would otherwise require it for lifelong drainage. And this again has excellent clinical data now to help support it, and in fact has given it to be an FDA-approved indication in the United States. So starting with its comparison compared to percutaneous gallbladder drainage, cholecystectomy, the DRAC-1 trial showed that there were fewer 30-day and 1-year adverse event rates and less recurrence of acute cholangitis, and no difference in the technical or clinical success or adverse event rates. And then compared to transpapillary drainage, which means performing an ERCP, placing a double pigtail stent through into the cystic duct and into the gallbladder, there were higher technical and clinical success rates with using the LAMS, as well as a lower recurrence of cholangitis. So overall, EUS gallbladder drainage is preferred compared to these modalities. And when we compared it in a trial to laparoscopic cholecystectomy, they found no differences in technical or clinical success, length of stay, adverse events, or recurrent cholecystitis and reinterventions, suggesting therefore that it is a very reasonable alternative. This was in studies of patients who were not necessarily, who are poorer surgical candidates, but this is, I think, now being adopted for all patients. Again, this has reached the point where it has been accepted in guidelines. For example, this is the most recent AGA CPU that does include EUS-guided gallbladder drainage, particularly for failed transpapillary drainage attempts, or for patients who are not necessarily surgical candidates or have an underlying duodenal obstruction, already have a metal stent in that occludes the cystic duct, or have a large stone burden within the gallbladder. So we have seen now good adoption of this technique supported by good clinical evidence. What about EUS-guided hepatobiliary procedures? So there are quite a number of procedures that can be done. For example, choledochoduodenostomy, hepatogastrostomy, rendezvous procedures. So what is the role of Axios here? Well, if we think about failed ERCP, why does it happen most commonly? The inability to access the papilla, such as duodenal obstruction or ampullary masses, altered anatomy from surgeries, or obstructive stones that don't allow for cannulation. Contraindications to EUS-guided ERCP include, again, ascites, inability to have a longer distance between the target lumens, or other reasons for not being fit for endoscopic procedures. So as I mentioned, there's many different directions that we can go in EUS-guided ERCP, and many different procedures we can perform, whether performing direct access or performing rendezvous. Where does Axios, or where do lumen opposing metal stents fit in? That would be in EUS-guided choledochoduodenostomy, where you have a dilated duct greater than 10 millimeters, and here you see the Axios being placed inside, the flange being opened. Again, same technique. The stent is pulled back and retracted against the wall, and then the second flange is opened in the scope itself. So what is the role for EUS guided bile duct drainage compared to ERCP, for example, for primary palliation? Earlier studies were very kind of contradictory in terms of their results. Some studies showing no difference in efficacy, and other studies showing EUS guided bile duct drainage having a higher technical success rate. I don't think that clock is for me, but now we have an excellent study, very well-designed study called the Drambo study, which is looking at choledochoduodenostomy using specifically the LAMS, comparing it to ERCP as first-line therapy for distal malignant biliary obstruction. And you see that there are higher technical success rates with the EUS-guided procedures, shorter procedure, and overall no differences in adverse events. And so in terms of size of the stent, there were some issues with the smaller stent, 6 millimeters compared to 8. So it is recommended that the larger stent be used. But overall, the recommendation is that EUS guided drainage be preferred if you anticipate a difficult ERCP in malignant distal biliary obstruction. Of course, can someone just tell me, is that time my time? Okay. Of course, it is important to remember about complications, as has been mentioned in many of these other procedures, and you have to be ready for them. So in this case, the Axios was deployed, but the flange was migrated out of the bile duct. And so we had to salvage this by placing a wire into the bile duct and then placing a fully covered metal stent once we had wire access in order to be able to secure the leak. If we can drain the gallbladder and we can drain the bile duct, what about draining the gallbladder for bile duct drainage? So this study by the Italians did show that this can be a successful procedure for patients with distal malignant bile duct obstruction where you cannot perform direct choledochoduodenostomy, so they drain the gallbladder instead. There's also enteral access procedures, for example, for gastric outlet obstruction. As we know, that can be caused by multiple malignant and benign reasons, and our traditional options include surgical anastomoses and enteral stenting. Of course, this is the EUS-guided GJ procedure that has multiple techniques, but the most commonly proposed technique is the direct gastroenterostomy technique or water immersion, where you fill the small bowel distal to the obstruction, create almost a pseudocyst, and then place a lumen-opposing metal stent using the directly enhanced cautery version. ESGE endorses either 15 or 20 millimeters for this procedure, and we also have excellent clinical evidence that this is a good option. In this study called the Drago study in malignant gastric outlet obstruction, the EUS-GJ version group had 4% need for reintervention versus the stent group that had 29%, with no differences in survival or adverse events. This has also now made it to guidelines and algorithms, particularly for patients who have a prognosis that's greater than 3 months. And then similarly, we can use this just for access for other procedures, such as the EDGE procedure in patients with Roux-en-Y gastric bypass. This can be performed in 1 step or 2 steps, where you place the LAMS, come back and do an ERCP, or you do it all at one time. I just want to point out the ESGE does again recommend 15 or 20 millimeters, but using a 20 if you plan to perform this all in 1 step, and also securing the stent in place. And lastly is for anastomotic strictures, so not really using the electrocautery enhancement feature of the stent, but just using the fact that it is a wide diameter, short length stent with lumen opposing features. And this has also been shown to be very successful. We don't really have great data on it, but it is a use that I found most often for things like esophagogeal anastomotic strictures. So our questions we do have now that we're using this more often, what about bleeding and occlusion? When should we remove this for patients like EUS-guided GJs? Do we leave this in forever? Gallbladder drainage, do we leave it in forever? We have to figure out the answers to those questions. But for sure, this is a disruptive innovation. It is allowing us to shift from surgery to endoscopic management of a number of issues. And it's a very exciting direction of our field. Thank you.